Fantastic. So, hi, welcome everyone for this August USIG session. It's just some simple case presentations and some discussion between us. So, I understand we've got, so here we're in Sydney at Nepean Hospital. We've got Carton, who's coming from Wollongong, Vinod down in Melbourne, Ramsey, remind me where you are at the moment, Ramsey.
Brisbane,
excuse me, right. And obviously we've got Townsville up in Queensland. We've got Alison Main joining us from, who's come all the way down from the Northern Territories, from Alice, who's joining us, about to do a DDU this weekend along with Anil. So again, we're all wishing you the best of luck, guys. And Stan will be joining us from St George in a moment. So without further ado, maybe I'll kick off and show you a case that we had coming through here a couple of months ago. So we had a young lady who's 58 years old. Sorry, let me just try and move that a bit. Fantastic. So we had a 58-year-old woman who came into our unit after a MET call. So it was just before angio. She's sitting there in the pre-angio suite. She'd been transferred from another hospital where she'd arrived from there. And this other hospital is about half an hour away. They don't do routine angios up there. This lady had been admitted. She was had some chest pain, some shortness of breath. There was some weird story of diarrhea and bright PR bleeding, and she'd had this fall. But with the shortness of breath, she had a troponin done that came back at 5,000. She was stable up there, so she waited over the weekend to come down on a Monday to have an angiogram done with us down at Nepean Hospital. Medical history included hypertension, and she was an ex-smoker from a while back. She was on aspirin, Somac, SSRI, escitalopram, metoprolol, atorvastatin, GTN, and aspirin. So this is the first study. I don't know, maybe we can pick on some of the guys who are doing the DDU. Maybe we can start with Anil. Do you want to maybe try and take us through an image or two, and we're going to see if the qualities are good enough for you to do that.
Okay, can you hear me, Sam?
Perfectly. Can everyone else hear Anil? Right. Go for it.
So there's a parasternal long axis view, and it's a usual run-of-the-mill ICU sort of parasternal image with suboptimal image quality, grainy image.
And my image is out again, aren't you? That's fine.
Okay. So what I can see is in terms of chamber sizes, the RV is looks normal size and contracting well. The left ventricle probably appears maybe a little bit dilated, and although I'd like to measure it, the wall thickness appears normal. In terms of contraction, there is the overall function is probably at least mildly reduced. The basal segments seem to be contracting and reasonably, although the infralateral wall appeared to be hypokinetic. The septum is contracting well. Can't comment on the apex on this.
Nice. I'm sorry, I forgot to say what the MET call was for. So she had this acute onset of shortness of breath and some hypotension that resolved after a little bit of fluids easily.
Right. So LV is well filled.
Good.
And so she had hypotensive.
Yeah, she was hypotensive. She needed she was given a bit of fluid on the basis of the history. She wasn't given a lot of fluid and was elected to be started on inotropes a little early. So she was just on like 2 of NORAD or something when she came down. Or it was metaraminol, excuse me, it was just going through peripherally.
Yeah.
Obviously when she arrived, we did the echo. That's great. I'll just show you the next image.
All right. So there is so this is a color grid on the mitral valve, showing at least moderate mitral regurgitation. This is a posteriorly directed jet, and estimating the severity is obviously difficult because of the Coanda effect, and it's probably underestimating the severity in this view. At least moderate, I would say, maybe more.
Very nice. Might pick on Alison for this one now. So thanks for the next couple.
Can I comment on the 2D image of the mitral valve?
Oh, certainly. Go for it, yeah.
So the anterior mitral leaflet does not seem to be coapting in a usual way with the posterior. I think it is coapting a little bit towards the left atrial side. So maybe there is a bit of flail on the anterior mitral leaflet, if I can see it properly.
Yeah, very nice.
And yeah.
Yeah, and good. We might come back to that. Excellent. I'll let Alison take the next bit.
So it's parasternal short image at the level of the papillary muscles. The most obvious abnormality is the left papillary muscle seems to be waving in the breeze.
And sorry, you said it's the left papillary muscle?
Sorry, right.
Posteromedial.
Yeah, sorry, but again, help us out with the papillary muscles.
No.
And also we've got Ramsey, you help us out with the pap muscles?
Yeah, so inferior medial.
Nice, and so you got, the inframedial and anterolateral papillary muscles. Cool. And absolutely, we got this one that's flapping around in the breeze. Ramsey, do you want to keep us going?
So that's the parasternal short axis view at the level of the aortic valve, and that's the color Doppler of the tricuspid valve. Again, demonstrating at least moderate regurgitation.
Cool.
It's hard to quantify that. So that's a spectral Doppler of the tricuspid valve regurgitation with a max gradient of 36. So,
nice. And how about us? Help us out with the regional wall on this one.
Yeah, so it's quite obvious that the inferior or the posterior wall is not contracting well.
Yeah, cool.
That's hypokinetic. The posterior septal is all hypokinetic.
Yeah.
It's hard to comment on the anterior and the anterolateral wall because the endocardium is not really seen well.
Yeah, right. That's another one of my bad views, isn't it, Anil? How about that one?
Yeah, so again, consistent with the posterior and the posterior septal hypokinesis.
Yeah.
Again, lateral wall not can't really comment very well. The septum seems to be thickening really well. Anterior wall's thickening well.
Excellent. Hi, Stan. How are you going? Stan's just joined us from St. George. Can you hear us, buddy? We'll give him a little bit of time and we'll just check he can hear us. But hi, Stan.
Hi, Sam. I can hear you.
And can you see the images okay?
Yes, excellent.
Fantastic. And can you see everyone else? Because we got Carton, Vinod, Ramsey, and Townsville as well.
I can see everybody.
Great. Excellent. Well, hi, welcome. We're just showing this case of a lady who came down from a MET call from a pre-angio who presented with a non-STEMI. And she had some hypotension and shortness of breath, which started acutely. And we've got, basically got to a stage where we said that we've got some inferior segment at the base and the midsection, which appears akinetic or hypokinetic. And we're looking sort of also at the lateral wall and the infraseptal segments. So it looks like we're dealing with, it doesn't look thin to me, it looks probably normal in thickness. And when I was looking at this, it looked to me like an acute vital infarction affecting this inferior and infralateral sections. And one of the big things that we were seeing was that there was, it looked like the, maybe not the anterolateral or the posteromedial, is something that's flapping around in the breeze. And it was particularly the anterior mitral valve leaf that looked like it was either flailing or prolapsed to some degree, where we got up to. But one of the things we're just trying at the moment, Stan, is to just everyone's having a little bit of a go to see if we can do this, a bit more of discussions with each other rather than just one person reporting. So maybe Vinod, do you want to go? What do you see on this, Vinod? Well, Vinod, if you take yourself off the mute, you've got the mute going at the moment. I can do it actually. Hang on. Try that. Okay.
This is a parasternal short axis view at the level of the mitral valve leaflet. And the main thing that we see is the anterior leaflet is, I think it's a flail anterior leaflet there.
Yeah.
And regional wall motion abnormality again involving the inferior wall. I can't see the anterolateral wall that clearly, but the septum appears to be thickening.
Yeah, perfect.
Normally.
Yeah, and Stan, the other thing that's happening is everyone's been quite rude about my images as well. We've got inferior image quality on all of this. I'm going to blame the software. No, it's probably my images. How about this one? Just take us again through this one, Vinod, while you got your...
You want me to?
Yeah, do you want to just carry on?
There is an eccentric severe mitral regurgitation. Again, looks severe, but it is directed posteriorly in this view. looks very turbulent.
Nice. Don't worry. Yeah, good call. Okay. How about this bad boy? I'm going to bring this back to our DDU guys now. So if I was going to be putting something like this in a DDU exam, this is the one that I'll be sort of, these are where sort of the money shots start coming in. So, Alison, come on, help us out again with this one.
So the anterior mitral leaflet appears to be prolapsing
Yeah,
into
nice.
the left atrium. The papillary muscle, there's a mobile mass within the left ventricle, and it appears to be the papillary muscle that is also flailing. The left atrium's at least moderately dilated.
Yeah, nice. Let me show you that picture.
So you've got mitral regurgitation that is eccentric and looks as if it's going back into the pulmonary vein. So it's again suggests it's severe.
Yeah, cool.
But you'd want to look into the pulmonary veins and signs of pulmonary hypertension. So pulse wave Doppler in the pulmonary veins, and it looks like you've got systolic reversal of flow in that vein.
Indicating
Mitral regurgitation.
beautiful, beautiful, fantastic. The next one, Anil, this question is for you. I'm just about to show you a pulse wave Doppler of the mitral inflow view. Why is this view helpful?
Why is this view helpful? Well,
Why have I particularly shown this in regard to this case?
so there's increased inflow secondary to the severe MR, so the E velocities are high.
Yeah, and what normal value do you have to suggest on the inflow, if it's above a certain parameter, it's associated with the
EA ratio, EA ratio should be less than 2 if it's normal. If it's more than 2, it's not mitral stenosis. It's increased inflow, increased volume coming into the LV from the.
Fantastic. So it's not the E to A ratio. It's a different one that we normally look at. So it's different. You're on the right track. It's something to do with the E wave velocity.
So the E wave velocity is, at the moment, it's 1 meter per second.
Yeah, and do you remember the value if it's over that? It's associated. It's suggested in this kind of circumstance to point more towards severe. Do you remember the value? It's normally it's like 1.2 or 1.3 meters per second. If it's above that, that's associated with more like severe or significant, should we say, mitral regurgitation. And this one wasn't. And I don't know whether that's just because I got my angle slightly off. It would have just made the cherry on the cake if that was above 1.2, but that's the reason why I added that one in.
Well, could it be because the LVEDP is high now?
Yeah, very nice. Absolutely. Yeah. I was just wondering with the acute setting, I was wondering whether you're more likely to see it though, but good call. Maybe it's just because the LVEDP is high. Because as you said, the ejection fraction is not perfect, is it?
Yeah.
Here's just another nice picture of that pat muscle. And in terms of flail or prolapse, I mean, for me, I think I've labeled this as prolapse just because it felt like the cusps were still sort of together, but not quite. The conjoining wasn't perfect. Flail would be all the way down. I don't know what other things for that. I think I called it a prolapse on this one rather than a flail.
I'd call that a prolapse.
Yeah, I think it was a prolapse.
The tip's still inside the ventricle.
That's
so
right.
I
Yeah.
call it a prolapse.
It's not pointing towards the LA. Yeah, that's right.
Sorry, I don't know who's met. This is Ian Seppelt, who's one of the other consultants who works down here, and this is everyone else.
Hi, Ian. Everyone knows Ian, I think. So,
Yeah, I think so. So this one was interesting for me. So here on the, I thought I got a good angle. I was happy that I got my closing click on my LVOT trace, and here we can see the VTI of about 11.4. 11. On average around about 11, suggesting we got really reduced stroke volume. What was quite interesting for this lady is she'd actually come off inotropes by the time, I was halfway through this study. She's actually cardiovascularly stable, sitting up, talking, relatively clear chest x-rays. She's not feeling unwell anymore, and she's just settled down with a bit of simple, hour of inotropes and about 250 mils of fluid. But I thought this was a really good example of someone who's kind of compensating pretty well for something. You know, she's got a poor stroke volume. Maybe I haven't got it perfectly, but 11.4, you know, she's probably got a stroke volume of about 40 or 50 mils. She's got a normal blood pressure, not horribly tachycardic, not the worst LV ejection fraction you've ever seen, but I think she's got quite, you know, she's got poor blood flow going on. And I think if you leave her like this for a long period of time, she's going to get into trouble really quickly. And I kind of had her labeled as a bit of a time bomb, basically. I looked at her right ventricle. I thought her right ventricle was down just a little bit. He got a TAPSE of 15, but, you know, hadn't blown out. She got this pulmonary hypertension, which I thought was about moderate. But again, she, you know, sitting there with peak gradients of about 30. She had a big dilated IVC. A few other pictures here nicely showing that inferior wall akinesis or hypokinesis in the mid segment with this beautiful Coanda effect and that jet coming all the way around to the back of the left atrium, sort of hugging that wall. And so I felt this was definitely, along with that pulmonary vein systolic flow reversal, put it in the severe category. And maybe a bit of a nicer view in the apical 3-chamber view of that infralateral basal and mid segments being akinetic or hypokinetic with the prolapse coming on. I thought this was quite interesting. I don't know what you guys think of this. I don't know. I tried to get this angle as best as I could, but I was sort of wondering whether we've got a little bit of a cutoff sign coming on. You know, it doesn't. I think a severe MR, because sometimes they describe it being associated with finishing before the end of diastole on the ECG, and so finishing a bit sooner. But it felt like it had quite a high cutoff, suggesting, again, pointing towards severe. But I think it's tricky when we've not got a perfect angle with it hugging the wall of the jet. But I don't know what everyone else thinks of that. And this is the final image, just a subcostal short axis view showing the inferior and infralateral walls of hypokinesis. So in summary, I said I thought this lady had normal LV size. The ejection fraction was maybe mildly impaired, but not horrific, but definitely had some nasty inferior and infralateral wall akinesis or hypokinesis with this ruptured anterolateral papillary muscle from this circ territory, non-STEMI, and as we know that chamber's just that papillary muscle is got a single blood supply from the circ.
So, sorry, Sam. Would that be ruptured posterior medial pap muscle rather than let's forget.
Yes, so sorry. Excuse me. Posterior medial. Sorry, I've put that as the typo, preparing it at the last minute. And associated with severe eccentric MR. And needed urgent valve repair. And I think actually, Stan, you might have looked after this lady. She was urgently sent down to St. George for valve surgery. And the way that she was, again, remained completely stable throughout the whole process of this. And, you know, she got transferred down, not needing any support at all, just had access and an art line in. And I understand she remained like that for about 24 hours and went and had surgery on very minimal support and did pretty well. So it's quite interesting to see how well you can cope with this, because I thought she'd be in strife pretty quickly for someone who had a, you know, stroke volume of about 40 mils or something. So yeah, it's just a quite cool case, I thought. Were there any questions or comments on that?
Sam, did you consider to put her on a balloon pump?
Yeah, interesting. We talked about that a little bit. So in terms of the transfer down, because she was stable, we said that we'd keep her on that for the time being and didn't put one in. And we talked about it with the guys who were on, the cardiothoracic surgeon and the cardiologist who were on, and they said, given her level of support at the moment and the fact that I had transport arriving there within like half an hour, 45 minutes, they thought it would delay her transport, make it a little trickier to do it. And they said just scoop and run, which I thought was quite reasonable. They didn't stick one in before they sent her to surgery. What do you think about that?
Look, it's a call. Everybody makes different call on those. She wasn't in a strife, so there was no absolute indication to help her at the time. I guess major concern about patient like this will be that more chordae will be ruptured. soon after, and then MI will become so profound that she will decompensate very quickly. In fact, it would be instant decompensation if the leaflet would become totally flailed. And then she probably would crash and burn. But look, it's a matter of a call, and it's always individual. I think scoop and run is a good policy sometimes. So whatever works.
Interesting.
To support that, Stan, to transport even around Sydney on a balloon pump adds a huge amount of complexity and time. While the retrieval services are set up to do it, it's not quick. And I think you'll add an extra few hours for your transport.
Because I think I'd also managed to arrange the transport that was fastest was also just ambulance with paramedics, and we sent her down with our own staff. I think to actually transport someone with a balloon pump,
It'll take
probably takes a little bit longer. Actually, it's retrieval.
It'll take a few hours to mobilise the team and get them here, and then there'll be more stuffing around. And she'll arrive at St George in 5 hours, not 1 hour.
Yeah, look, I agree. I sent you one recently, Stan, that got a balloon pump shortly after they arrived. I'd like to think that was a perfect call, but you can't put a balloon pump in a helicopter, you know? So
Yeah.
You can, but it's hard.
it is. How soon do you think they need a repair? I sent you one a few weeks ago, Stan. It was Enterococcus endocarditis that ruptured, you know, mitral valve, and it was sort of difficult because they wanted antibiotics on board, you know, and LV eventually started to dilate, and mitral recurrence became severe, but it was a difficult balance, a little bit difficult. That one looked ischemic. Am I right in thinking that this was an ischemic rupture, or in the case that you presented, Sam, or?
Sorry, can you say that one more time?
What was the etiology of the rupture? Was it ischemic, or?
Yes, just ischemic. Yeah, absolutely. So she'd come in after a fall. There was some ECG. I think it's a minor ECG changes in that troponin elevation, but she was completely stable up in Hawkesbury Hospital. And it was only when she came down to us 2 days later for the angio that she had this sudden sort of deterioration that responded relatively quickly with relatively minimal intervention.
It's an interesting dilemma, you know, but I agree, balloon pump transfer is impossible. Next near to impossible, I could tell you know, to organize.
Yeah, I sort of lean that direction as well. I think if I was sitting there in a cardiothoracic centre, I'd have just stuck the balloon pump in though.
Well, look, a balloon again, if it's a cardiothoracic center and they already arrived, it's the best is probably take them just to theater while they're stable, not to wait until they crash and burn. Balloon will just delay again things because just putting the balloon itself takes time. If they need it, they can put it in theater. But looking at this echo, it's probably a single vessel that was really in trouble. I mean, she may have multi-vessel disease, but definitely single vessel that caused the trouble at the time. And it's probably better to just get it fixed and not to wait until something else goes sour. I mean, they may put balloon in theater if there is a problem, but she wasn't burning and crashing and probably would be just fine to go on a bypass and have the valve either repaired or replaced.
Cool. Vinod, did you have another case that you'd like to present?
Yes, Sam, I've got a case to present.
Fantastic. Maybe I will stop sharing my screen,
Okay.
and I will let you. Stop share. And Vinod, if you at the bottom of your screen, you'll have something that says share screen. If you could click on that for us, we should be able to get yours up.
Okay.
I think I have to make you a host. Hang on a sec. Try that.
You are the host now. Can you hear me?
Yeah, perfectly, yeah. At the bottom of your screen, you've got something that says share screen, and then you just choose your whole screen and go from there.
Share screen and
You got it? Yeah, perfect. Vinod has started screen share. Perfect, yeah, we got it.
So we have a 62-year-old male who presented with chest pain to the emergency department of the Alfred Hospital, who had inferior wall MI, who was taken to cath lab. RCA was the culprit lesion and it was stented. And subsequently, the patient was transferred to the coronary care unit where he had a MET call for hypotension. So on examination, the patient was who had cold peripheries, poor perfusion, and was hypotensive with the systolic of 80 millimeters of mercury. Patient was transferred to the ICU where he was commenced on inotropic support and an echo was ordered. So this is the parasternal short axis view. Again, I think if people are commenting about your scans, Sam, this is probably going to be, from 0 to 1, this is probably going to be closer to 0. So this is a parasternal short axis view of this patient. So I'll just, there is no significant finding on this. So I'll just jump through to the next view with the color. And this is the one which is going to give the diagnosis, I think. So this is the parasternal short axis view at the level of the mitral valve leaflet tips. And what you can see over here is a defect in the inferior septal wall of the interventricular septum. And when we put the color, what we see is a color flow going from the left ventricle to the right ventricle. Again, this is at the level of the papillary muscles, mid segment. And here, the important thing to note is the endocardium of the LV seems to be intact at this level, whereas there is a defect on the other side. Let's move to the apical 4-chamber view in this patient. And the important thing that we see is the RV is enlarged compared to the LV, severely enlarged. And there is a defect, a ventricular septal defect or ventricular septal rupture, which you can see in the mid segment here. And the other thing that we notice here is the interatrial septum, which is bowing to the left side, suggestive of high right atrial pressure compared to the left atrium.
It's strange it's so small, isn't it, Vinod? I mean, I haven't seen a huge number of these things, but it's quite small. It's quite strange that it's so small, don't you think?
Yep. We move to the next one. You will see the extent of it. So this is the color flow, that Doppler showing the left to right shunt in this patient. So, and then we pan posteriorly or to the inferior walls. You can see the coronary sinus here in this patient, and what you see is a large defect in the ventricular septum, mainly involving the basal and the mid segment. And when we put the color in that area, we see there are at least two jets which are going from the left to the right. And then we put a color, then we put the continuous wave Doppler through this jet over here to estimate the gradient between the two chambers. So the pressure gradient between the left ventricle and right ventricle is close to 70 or 70 millimeters of mercury, as you can see in this patient. So there is a formula to calculate the right ventricular systolic pressure or the pulmonary arterial systolic pressure in these patients with ventricular septal rupture, which is shown over here. So it's the difference between the gradient and the systolic blood pressure or the left ventricular systolic pressure in the absence of aortic stenosis or subvalvular stenosis in this patient. In this patient did not have aortic stenosis, so, and his systolic was about 90 millimeters of mercury on inotropic support. So the velocity, the gradient across the chambers was about 70 millimeters of mercury. So the estimated right ventricular systolic pressure was about 20 millimeters of mercury in this patient. Having said that, you can see that there are two jets in the previous Again, so we have been able to interrogate only one of the jets in this view. So then the other thing that one has to calculate in these patients with ventricular septal defect or any intracardiac shunt is the QP-QS ratio. And we calculated that in this patient. So the RVOT-VTI in this patient is about 20. And the LVOT-VTI in the patient was about 10. And the LVOT diameters and the RVOT diameters were exactly the same, about 2 centimeters or close to 2 centimeters in this patient. And the estimated QP by QS is about 2. So what it means is there is twice the amount of blood flowing in the right ventricle compared to the left ventricle.
Can I ask you a question, Vinod? Actually, this is a question more for Anil, as our Anil and Florian as being the guys who see the most congenital heart disease. From my understanding, I understand that the QPQS had kind of gone out of fashion because it's so easy to make mistakes and so easy to get things wrong. What do you think about the use of QPQS in these circumstances?
We see a lot of VSTs. We never measure QPQS because there are problems in miscalculating the RVOT size. It's prone to so much errors. Okay. And second thing, in the context of the clinical state, and the gradients give you much more information. I mean, this is an acute VST. This is not a chronic VST. So you would expect the gradient to be high because the RV is not adapted yet.
Yeah.
If the child was born with a VST this size, then the RV will, or the LV would have volume overload. So we will have other things to know it is how significant it is. But in setting of an acute VST, I think the degree of pulmonary edema, the degree of hypotension, and the clinical effects of its existence give much more information as to how severe it is. The gradient suggests it's 70 millimeters mercury. That would point toward a restrictive VST, but this is not a restrictive VST. This is creating havoc for this patient. This is much more significant than what these gradients and this QPQS shows.
Interesting. Thank you. Sorry to interrupt, Vinod.
Yeah. And the TAPSE was about 1.7 in this patient. And when we do look at the two-chamber view from the apex of this patient, what you see over here is a large aneurysm, which is involving the inferior wall. And the diameter was close to 3 centimeters in this patient, as shown in this slide. And then we looked at the IVC size and variation with respiration. As you can see, there is no significant variation. This patient was not intubated. And we don't see a significant variation with respiration in this patient, suggestive of high right atrial pressure. So this is the 3D volume in this patient. And again, what we see here is a defect in the inferior septum of this patient with the aneurysm involving that area. And this is a color 3D in this patient again, using which sometimes people measure the diameter of the defects. So now coming to the ventricular septal rupture, it's a very rare complication. It used to be about 1 to 3% prior to the PTCA or the coronary intervention era. And now after the coronary intervention using stenting has been introduced, and the complication rate is reported to be about 0.13%. So it usually occurs in the first week after myocardial infarction, and it's not uncommon to see patients with these complications within 24 hours of their presentation. And the most common locations are the apical septum and the basal inferior septum. So the apical septum is when the left anterior descending is the artery vessel involved, and basal is when the RCA is involved. And in this patient, the RCA was stented, and which was found to be the culprit lesion. It can be classified into simple when there is a direct connection, straight connection between the RV and LV, and it's usually in the apical segments. And it is complex when it has got a circuitous tract and it's usually found in the basal segment involvement, which is RCA territory. The important thing to notice is the blood supply of the interventricular septum. As you can see, the interventricular septal, the basal interventricular septum is supplied by the RCA, and the inferior is supplied by the basal, and mid segments are supplied by the RCA in the three-chamber view. And in the basal short axis view, again, this is the segment which is involved. This is the segment which is supplied by the RCA. So we can see that the lesion in this patient was confined to the RCA territory, and this is where the patient had the ventricular septal defect. And we had about 5 cases over the last 4 or 5 years here, and these are the image. These are the echo views from them. Again, this is involving the basal segment in the patient with the left to right shunt. Another patient who had a big aneurysm involving that wall with the rupture, which is at the tip here. The role of echo in these patients is mainly to identify the defect. One has to pan through the interventricular septum to identify the defect. So sometimes we have to actually use non-standard planes to find the position of these defects. And sometimes these can be masked by the papillary muscles, the trabeculae in the inside the RV. And the echocardiography helps in not only identifying the location, and also determining the size, estimation of QP, QS shunt ratios, and the gradient across the chambers. And with this patient, these patients, the mortality can be up to 44%. So this is one of the patient groups where the surgical mortality is very, very, very high. And in these patients, early repair is considered to be a death sentence for these patients. Later the surgery, better is the outcome from various databases which have reported their outcomes.
And is that just because, sorry to interrupt again, and is that because that they think that when it's if you wait for a while that the scar tissue will form, and is that something you can like latch onto when you're putting in a suture?
Yeah, usually these patients require a patch repair in that area, and when they go in an acute stage, often there is no scar tissue and as soon as they go in, there is only friable tissue, and most of the times patients bleed to death. Or they die because of complications. One of the main challenges in this patient group is that you can't actually wait for 28 days, which seems to be the optimal period for surgery in these patients with that sort of defect. In these patients, the cardiac output was just about 3.5 liters, and he had mottled peripheries. Although it had improved with inotropic support, if we had left him on that for some time, he would have probably ended up with multi-organ failure. So in order to prevent that from happening, he was put on VA ECMO while waiting for surgery. Surgery happened after about 14 days, and then I'm just going to show the echo appearance on transesophageal echocardiography after the repair. So you can see the patch which has been put on that segment, and there is no residual ventricular septal defect that was seen on color flow Doppler. Having said that, sometimes you can see tiny circuitous tracts still after repair in these patients, but most of the time it is okay. What we don't want to, as long as they have adequate cardiac output after the procedure, most of the times the surgeons will be happy. And this patient was decannulated subsequently after 2 days after this surgery. So in our centers, we have done about 5 of these patients, and all of them have gone on ECMO prior to their surgical repair of their ventricular septal defect. Thank you. Any questions?
A great case, Vinod. Thank you very much. Any other questions for Vinod?
Pericardial patch, Vinod?
Hmm?
Did they use pericardial patch?
Yes, bovine pericardial patches.
We had a few, mortality is very high. Mortality actually in a rupture with pericardial patch is up to 70%. Reportedly depends where it's done. I guess with Vinod, they seems to be all survived.
Oh, this is the ventricular septal ruptures. I'm not sure.
Extremely high mortality, yeah. I guess one of the surgeries that sometimes is used is when the defect is very large, one of the surgeries is a partial exclusion of the left ventricle with pericardial patch. When there is absolutely nowhere to put the patch of pericardium, which is small, then the part of the ventricle which is infarcted is totally excluded with a very large patch of pericardium. So virtually like a sail across the ventricle. And we had one who had virtually half of the ventricle excluded a couple of weeks ago, I think. Carton, you may remember that patient.
I do remember it well, yeah. But sequentially had additions to it, I remember. But I agree, maybe VA ECMO to allow scar tissue might be the way to go. I hadn't realized that's what people were doing,
But it's very hard to wait 4 weeks on VA ECMO either. You can't.
We can, as long as they don't have complications on ECMO.
And do you wait 4 weeks, Vinod?
So, about 10 days, it seems to be the optimal period for the surgeons to take these patients back to theater for repair. But we have seen it up to 2 weeks. It depends on their multi-organ failure, resolution of their organ failures. So this was probably straightforward. It was immediately picked up, and it was he was put on ECMO, and subsequently uneventful ECMO run and had the repair closed, and he's in the ward at the moment, but getting ready for discharge in the next few days.
Well, that's interesting because that would change our referral pathway. If we actually get one.
I'm not sure because our surgeons are keen to put these patients on ECMO while they're waiting, and I'm not sure. Different surgeons may have different preferences. Because at Westmead, where I was working, when we diagnosed this complication, the surgeons actually took the patient to theater on the same day and repaired it, and the patient survived. So
it's funny. We had a similar patient. I don't remember. I showed it a case a couple of months ago, and the surgeons said the same thing. They would delay it. They wouldn't take him to surgery unless it was 10 days later, and they were refused ECMO because of high mortality and complications. Funny, it's depends what centre and what surgeon you've got, I guess.
Yeah.
Well, guys, can I say thank you very, very much for everyone for joining in. As I understand it, there are no other cases for anyone to present at this time.
No, Sam, look, I have to say the technology is a huge improvement.
Maybe just before we talk about that, maybe I could just ask Vinod to make me the host again. I'll just stop the recording and then maybe we could talk about that for just a second.
So how do I do that?
Just hang on, if I